we have discussed the basics of the WBC in the previous video, but in this particular video we're going to see specific disorders of the neutrophils. To understand the specific disorders of the neutrophils, it's very important to know what are the basic functions of the neutrophil. I told you the basic functions of the neutrophil can be told into three things. One is called chemotaxis, phagocytosis and killing. So phagocytosis and killing. So these are the three basic functions of the neutrophil. These are intracellular phagocytosis, intracellular function. Extracellular killing is also there, which you told next, which we're not going to discuss right now. But intracellular killing is based on this chemotaxis, phagocytosis and killing. So these are three processes which is involved in intracellular killing. So first, to understand the chemotaxis, because there are a lot of disorders that involve the chemotaxis of the neutrophils, so you have to know this particular diagram. So this particular diagram describes you the chemotaxis of the neutrophils. To have chemotaxis, you need four important processes. Process number one, you have something called margination. Process number one, you have something called margination, where the neutrophil comes closer to the endothelial wall. So that is what we refer to as something called margination. And second one, you have something called rolling. Second principle is something called rolling. So rolling is nothing but these are weak interactions in the endothelial wall. So these are nothing but weak interactions with the endothelial wall. This is what we call rolling. And then we have something called adhesion. So this is what we call it as stable adhesion. So these are nothing but strong interactions, extremely strong binding or strong interactions with the endothelial wall. So which means they get adhered to the endothelial wall. So this is what we call adhesion. And next thing, you have something called diapedesis, where the neutrophil tends to move in the gaps between the endothelial cells and the fenestrations and move into the tissues. This is what we refer to as diapedesis. And final component, we have something called migration. Finally, they migrate to the site of inflammation, and that's what is going to happen. So these are the things that contribute to something called acute inflammation. That's what you'll be given in your Robbins pathology as well. So this is what we refer to something acute inflammation. So the five processes in chemotaxis, that is, you have margination, rolling, adhesion, diapedesis and migration to the site of inflammation. So these are the five processes. So let us see what happens in margination. For margination, one of the important substances that is helpful in margination is what we refer to as something called a fibrinogen. Fibrinogen is a very important substance, and it's a very important positive acute phase reactant that is important for margination of the neutrophil, because fibrinogen causes Rayleigh formation and the RBCs that generally pushes the neutrophil away from the bloodstream towards the side of the endothelium. So this is what we refer to as something called margination. And after margination, the second process we are going to call it as rolling. So rolling, as I told you, is the weak binding or weak interaction of the neutrophils with the endothelium. So what are things that are important for rolling? So let us see. So as mentioned here, the selectins, the P-selectin, the E-selectin on the endothelial side are very, very important for rolling. So they like the endothelium starts expressing this P-selectin, E-selectin molecules, and the P-selectin and E-selectin expression is actually increased by, for example, the P-selectin expression is increased by histamine, and the E-selectin expression is increased by two important acute phase reactants again, which is important for inflammation, that is called interleukin-1 and tumor necrosis factor alpha. So they are going to increase the expression of these molecules. And once they increase the expression of these molecules, there should be associated ligands that's binding on the neutrophil side, isn't it? So what are the ligands for this P-selectin, E-selectin that are expressed on neutrophilic side is nothing but the most important one is something called sialyl Lewis X. So this sialyl Lewis X is a very important one. It is otherwise referred to as something called CD15S. So this is what we refer to as something called sialyl Lewis X. That's very important. That is the one that is going to bind with the P-selectin and the E-selectin. Apart from that, there is one more ligand which is not mentioned here, to be honest, which I can draw here. So this on the endothelial side, we are going to call as something called a CD, glycam-1 and CD34. So you can call it as glycam-1 and CD34. This is also one of the important molecules that is expressed from the endothelial side, and the associated ligand for the CD34 and glycam 1, on the neutrophilic side, we are going to call it as something called L-selectin. L-selectin will be expressed on the neutrophilic side, that is going to bind with the glycam 1 and CD34. So these are the molecules that are important for initial rolling. This is what is important. For example, this sialyl Lewis X may be deficient. One of the applied aspects of this is the sialyl Lewis X may be deficient in one type of leukocyte adhesion deficiency called leukocyte adhesion deficiency type 2. That's called leukocyte adhesion, even though it's a rolling defect, but this is also referred to as leukocyte adhesion defect type 2, which is usually due to the sialyl Lewis X receptor deficiency. So this is what is going to happen. So in summary, rolling is due to two important expression of the various molecules on the endothelial side as well as the neutrophilic side. Endothelial side, they start expressing the P-selectin, the E-selectin. P-selectin is increased by histamine and E-selectin is increased in expression by IL-1 TNF alpha. Apart from the endothelium can also express your glycam 1 and CD34. P-selectin, E-selectin binds to the sialyl Lewis X, which is also referred to as CD15S, and the glycam 1 and CD34 endothelial cell binds the neutrophil L-selectin as well. So these are the interactions that you have to know very importantly. And remember, this P-selectin, if they ask you where it is stored in the famous Weibel palette bodies in the endothelium. Because Weibel palette bodies are very important, because in the later part of the hematology lectures, we are going to see about the von Willebrand factor that is also stored in the Weibel palette bodies in the endothelium. So that is why this P-selectin is also stored in the Weibel palette bodies of the endothelium in the first place. So these are the different interactions. And remember, sialyl Lewis X defect leads to a very important neutrophil disorder, that's called leukocyte adhesion deficiency type 2. So next, coming to the adhesion. So what happens in the adhesion? Adhesion, as I told you, it is nothing but the strong interaction or strong binding of the neutrophil with the endothelium. So this is what we refer to as adhesion. For adhesion, you need this cell adhesion molecules. The name itself tells on the endothelial side, you have two cell adhesion molecules. They are also referred as integrin ligands. They are called as ICAM1 and here something called a VCAM1. ICAM1 is otherwise referred to as CD54 and VCAM1 is also referred to as CD106. So these are expressed on the endothelial side, and the expression of this integrin ligands, that is ICAM1 and VCAM1, vascular cell adhesion molecule and intercellular cell adhesion molecule, all these things are increased by the same interleukin 1 and TNF alpha. So the expression of this integrin ligands, that is ICAM1 and VCAM1, both are increased by interleukin 1 and TNF alpha. And obviously on the neutrophil side, you need certain receptors that can bind with this ICAM1 and ECAM1. So for example, the receptor that binds with the ICAM1, that is integrin ligand ICAM1, is nothing but the LFA1. That's called LFA1. LFA1 is otherwise referred to as something called a beta-2 integrin, which means these are for adhesion, your integrins are very important. That is why these VCAM1 and ICAM1 are called integrin ligands, because they bind to the integrins on the neutrophil side. So this is what we refer to as something called a beta-2 integrin, LFA1. This LFA1 has two components. I'll tell you why this is important to understand. This LFA1 itself has two components. One is called CD18 and second one is called CD11A. Because this deficiency of CD18 will result in deficiency of LFA1 and result in poor adhesion of the neutrophil with the endothelium. That is what we call leukocyte adhesion defect type 1. So that is due to poor CD18 production. That's a genetic defect. So CD18 deficiency results in leukocyte adhesion deficiency type 1. So that is due to integrin defect in the neutrophil. That is typically a beta-2 integrin defect, especially the CD18 of the beta-2 integrin. That is LFA1. And binding with the VCAM1 is mediated by another integrin called VLA4. That is called very late antigen 4. That's called VLA4. That is the one that is going to bind with the VCAM1, otherwise referred to as alpha 4 beta 1 integrin or simply a beta 1 integrin. That's all. So which means ICAM1 binds with the beta 2 integrin and the VCAM1 is going to bind with the beta 1 integrin, otherwise called as VLA4. So these are the defects, of various things that is important for adhesion and rolling. Then finally you have the fourth one, that is called the diapedesis. Diapedesis, that is movement in between the endothelial cells. For diapedesis, as already explained in this particular diagram, you need a very important molecule called as PKM1. You need a very important molecule called PKM1, or otherwise referred to as CD31. So this is very, very important. Expression of this PKM1 and CD31 by the neutrophil is extremely important for this process of diapedesis. How the diapedesis happens is because they produce a collagenase called type 4 collagenase. This collagenase is very important for dissolution of the endothelial basement membrane so that they can migrate through the endothelium. So very important. So they express something called a type 4 collagenase, and a very important molecule that is important for this diapedesis process called PKM1 or CD31. And CD31 is not only expressed on neutrophils, it's also expressed on platelets and endothelial cells as well. Apart from that, you have other events where you have something called migration. For migration process, you need a lot of other molecules. For example, very important is the chemoattractants. So a lot of chemoattractants are known for producing the migration of the neutrophil. So what are the chemoattractants? For example, you have leukotriene, especially leukotriene B4. Then you have platelet activating factor. All these things are secreted from the site of injury. Platelet activating factor. Then you have a lot of chemokines in the form of interleukin 8, kallikrein, then lot of complement fragments like C5a, and lot of bacterial products. Chemokines, complement, and bacterial products. So all these things act as chemoattractants for the neutrophils, so which typically tend to migrate to the site of inflammation. So these are things that are important. So you have this is what is going to be involved in chemotaxis, and you have a lot of defects that are associated with chemotaxis. So what are the defects of chemotaxis of neutrophil? Chemotaxis defect. So whenever the moment I call the chemotaxis defects, these are generally referred to as something called LADs, that's called leukocyte adhesion defects. So you have LAD type 1, you have LAD type 2, and you have LAD type 3. LAD type 1 we have already described. It is due to mutation in the gene called integrin beta 2, that is called ITGB2, and specifically the molecule that is defective is CD18 of the beta 2 integrin, which you have discussed already, isn't it? So already I told you about that. So then you have LAD type 2, that's called leukocyte adhesion deficiency type 2, where the defective gene is called FUC2, FUCD2, where the defective component will be Sial-Lewis X. So this is what the defective component. In fact, it's not only Sial-Lewis X defect, it is also due to defective fucosylation, because Sial-Lewis X will be active only after process called fucosylation. There will be defective fucosylation of all selectin ligands, not only Sial-Lewis X, all selectin ligands. So that's what is going to result in leukocyte adhesion deficiency type 2. But in general, one of the selectin ligands is Sial-Lewis X, and that is what is very important to understand here. That's why I told you that specifically. That's called LAD2, leukocyte adhesion defect type 2. And LAD type 3 is due to something called FERMT3, the FERMT3 gene that is defective here. And what is the primary defect here is all integrins will be defective, not only beta 2 or beta 1, all the integrins will be defective here. Integrins are nothing but ligands for your VCAM1 and ICAM1 cell adhesion molecules. So all integrins will be defective, which means activation defect. Especially all integrins will have something called activation defect. So which means, what is the problem? LAD type 1 is a primary adhesion defect because it involves that integrin, isn't it? CD18. So especially typically the beta 2 integrin. And LAD type 3 is also primary adhesion defect because it also involves integrin. Integrins means it's adhesion, we already discussed. But whereas even though it's called leukocyte adhesion defect type 2, LAD2 is actually a primary rolling defect. It's not a adhesion defect usually. So what are the general features of all this leukocyte adhesion deficiency type? And one more important thing is all are autosomal recessive, so it's very easy to remember. All are autosomal recessive in inheritance. The general features will be patient will be having recurrent infections, especially bacterial, because neutrophils are very important for fighting against your bacterial and fungal infections. So recurrent infections, typically bacterial and fungal, very important here. And second thing, patients will not have any pus formation because they cannot do chemotax. They cannot go to the site of infection. So how can you produce a pus if you don't have a site? They don't go to the site of infection. And patient will have leukocytosis because they cannot move and they stay within the vascular compartment. It appears the patient is having a high level of neutrophils. Simple. That's why you have leukocytosis. And patient will have delayed umbilical cord separation. And this is what is very important for exam key, delayed umbilical cord separation. Why they go for delayed umbilical cord separation? The reason is because this umbilical cord separation, you need neutrophils to remove the dead tissues and detach the umbilicus outside, because here the neutrophil migration is defective and chemotax is defective. You can't produce umbilical cord separation yearly. That's why you have a very delayed umbilical separation. This is a very, very key point in exams to diagnose a leukocyte adhesion defect. Very important. And next thing, patients may have Glanzmann's thrombasthenia like picture. So where the patient will have defective platelet adhesion also. So Glanzmann's thrombasthenia like picture. Typically this is seen only in LAD type 3, not in LAD1 or LAD2. And how will you diagnose? Type 1 is very easy to find out because it is typically defective CD18, so I can easily find out by flow cytometry. If you know the principle of flow cytometry, all the CD molecules, the moment it comes as CD, it's very easy to analyze by flow cytometry. CD18 defect, so see the amount of CD18 in the neutrophils. If it's low, it's straightforward diagnosis, that is LAD type 1. So flow cytometry is the gold standard here. This LAD type 2 and type 3 can be detected only by genetic analysis. Incidence is also very rare, and general treatment for all these defects is allogenic stem cell transplant. Nothing else you can do about it. It's a genetic defect. And then you have another form of chemotaxis defect that's called a lazy leukocyte syndrome. Lazy leukocyte syndrome. So here the main problem will be the neutrophil chemotaxis. It's also a chemotaxis defect where the migration of the neutrophil will be defective. Chemotaxis will not happen. But what is the cause of the disorder? We don't know. So what is the precise area of defect? We don't know. But this is what we refer to as something called a lazy leukocyte syndrome. So in this condition, I told you leukocyte adhesion defect will have recurrent infections with neutrophilia. But in lazy leukocyte syndrome, patient will have recurrent infections with neutropenia, not neutrophilia. They will have neutropenia. But remember, the bone marrow reserve is normal. The bone marrow granulocyte reserve is normal, which means in the bone marrow, the amount of granulocytes that are produced will be completely normal, but they can't move out of the bone marrow because of the defective chemotaxis. That's what we refer to as lazy leukocyte syndrome, and we don't have any known cause for this particular syndrome, extremely rare incidence. But how will you find out it's really a lazy leukocyte syndrome? Because you are going to use a test called etiocolonolone test. So where injection of this etiocolonolone normally results in increased neutrophil mobilization. Which means after injecting this, you have to see increased amount of neutrophils in the blood, or increased amount of neutrophils should be released out of the bone marrow. But even after injection of this etiocolonolone, if you don't see sufficient neutrophil in the blood and if you have still low amount of neutrophils, which means it's a chemotaxis defect, and you can diagnose this lazy leukocyte syndrome. This could be a very potential question in the basics. So that's called etiocolonolone test, so which is useful for identifying a defect called lazy leukocyte syndrome. Then you have the phagocytosis and killing process. The phagocytosis in the neutrophil is because of your receptor ligand interaction typically. So what are the receptor ligand interactions in phagocytosis? For example, you can tell the phagocyte receptor and the associated ligand. So you have something called mannose receptor, which typically has ligands in the form of mannose, fucose, and N-acetyl glucosamine. NAG, N-acetyl glucosamine. All these things are present on the surface of the organism. So these are some of the important receptors that are present in neutrophils that can identify the ligands, and they can, if the ligands are present in the particular antigen, they are going to phagocytose them. And second one, you have something called scavenger receptor, which is for LDL, low density lipoprotein. And next thing, you have opsonin receptor. Is very, very important. Opsonin receptor, where it's going to identify the Fc fragment, typically of the IgG molecule. Ig is an excellent opsonase, one of the best opsonases you can ever have. Ig molecule, Fc, IgG, and even they can identify C3b also. They have the C3b receptors. C3b also is one of the opsonin receptors. For example, let us assume the patient is having hypogammaglobulinemia, which means they're going to have defective immunoglobulin production, or if the patient is having complement deficiency. These kind of patients will have defective phagocytosis, because even though the opsonin receptors are there, because the antigens and the organisms, the pathogens cannot be opsonized properly because of low levels of immunoglobulins and low levels of complements, and that is the reason why phagocytosis will be defective in these patients. Some of the examples where you get defective phagocytosis. And then you have engulfment process before killing. Engulfment is due to production of something called pseudopodia. These are cytoplasmic extension. These are called as pseudopodia, which surround the target cell or the particle, and then they engulf. So once they engulf, they form something called a phagosome. These are like cytoplasmic, like plasma membrane invaginations that unite together to form a phagosome, where the organism will be within this phagosome. And once the organisms are within the phagosome, your lysosomes are there, which are going to fuse with the phagosomes, and they are going to fuse with the phagosomes, and they are going to form a new area called phagolysosome, and the killing typically happens in the phagolysosome only. That's all. This is the fourth step. After engulfment, this is the fourth step. First one is the chemotaxis, second one is the phagocytosis, third one is the engulfment, and fourth one is the killing. So killing is generally based on two basic processes. The first process on killing is you can depend into oxygen dependent killing, and second one you can call it as something called oxygen independent killing. Oxygen independent killing. So what do you mean by oxygen dependent killing and oxygen independent killing? Oxygen dependent killing involves the production of ROS, that is called reactive oxygen species. That's how they kill the organism within the phagolysosome. So they're going to produce something called, this production of reactive oxygen species is also referred to as something called respiratory burst, or otherwise referred to as something called oxidative burst. So how you generate a respiratory burst and oxidative burst? Let us go back to the original first diagram, where I mentioned here about the respiratory burst as well as the oxidative burst. It involves three steps. The first process is the production of something called oxygen free radical, where with the help of an enzyme called NADPH oxidase, this O2 is converted into a oxygen free radical. So this is the step number one. So whenever you have a defective NADPH oxidase, that is going to result in a disease called chronic granulomatous disease, which I'll tell you in some time. And second step in this process is conversion of this O2 to dangerous substances like hydrogen peroxide, like this H2O2. How this H2O2 is created? By another enzyme called superoxide dismutase. And this hydrogen peroxide is very important because after the production of this hydrogen peroxide, addition of chloride will result in formation of a molecule called perchlorate. They are going to produce a molecule called perchlorate, and generation of this hydrogen halide and perchlorate is going to be due to an enzyme, or this otherwise called as something called hydroxyl halide free radicals. Hydroxyl halide free radicals, and for this you need a very important enzyme that is called myeloperoxidase, MPO. This is also a neutrophilic enzyme as well. So, and you can have a lot of problems, like you can have myeloperoxidase deficiency as well in the patient. Remember, at the same time, if somebody asks you, whenever you see a pus, when you have a pus in some area or an acne somewhere, everyone would have seen the pus. So when you see the pus, it is like a purple green or blue green in discoloration. Actually, that blue green color or the purple green color of the pus is due to the myeloperoxidase. Very important. That is the reason what causes the blue green color of the pus, the myeloperoxidase content in the pus. So anyway, that is the one that is going to create this perchlorate and hydrogen halide free radical. Both are the same only. But one thing, all this is again a free radical which is going to kill the organism, isn't it? So these free radicals are generated because they have to kill the organism. That is why these free radicals are generated. Here free radicals generated, here also free radicals generated. All these are designed to kill the organism within the phagolysosome. But certain organisms that are catalase positive, can convert this hydrogen peroxide into harmless water molecules. That is why one of the defense for this microorganisms that are catalase positive might escape the oxygen dependent killing by the neutrophils. So what are the catalase positive microorganisms that escape this oxygen dependent killing? So, I mean, not like completely, but somehow they try to escape from this oxygen dependent killing by producing catalase enzymes. Catalase enzymes are produced by a lot of organisms. For example, it is also produced by like your Staphylococcus, very classic example. Staphylococcus. Then it can be produced by Serratia. Then it can be produced by Nocardia. Then by Aspergillus. Then by a species called Pasturella. Then it can be produced by Burkholderia species. Then it can be produced by E. coli. Then it can also be produced by certain organism Listeria. Sorry, everything you have told is on bacteria, but why one fungus is included? Because I want to form a mnemonic. The mnemonic for this, I am going to call it as bell snap or snap bell. You can remember as anyway. You can call it as bell snap or snap bell. So this is a mnemonic for catalase positive organisms. So Staphylococcus, Serratia, Aspergillus, Pasturella, Nocardia. You have Burkholderia. Then you have E. coli and Listeria. Apart from that, you can also remember Candida if you want. So all these are catalase positive organisms which can produce catalase so that they can try to escape this oxygen dependent killing by converting hydrogen peroxide to water by their activity of catalase. Remember, NADPH oxidase defect will result in a disease called chronic granulomatous disease, and this MPO deficiency also can result in certain defects. So what are the problems due to defective killing? The first problem due to defective killing, I am going to call it as chronic granulomatous disease. So what is the thing in chronic granulomatous disease? It's, first of all, it's an X-linked defect, and the problem 70% is X-linked, and even 30% can be autosomal recessive as well. But very importantly, what you have to know is it is the X-linked recessive defect. That's the most common. So apart from this X-linked recessive defect, one of the other important thing is what is the gene that is mutated. There's a problematic here that is called CYBB gene that is typically present on the X chromosome. And the pathophysiology wise, if you ask me, answer is it is defective NADPH oxidase. NADPH oxidase deficiency. NADPH oxidase deficiency, which means the moment you have this NADPH oxidase deficiency, they cannot produce oxidative burst. Defective respiratory burst or oxidative burst, which means they can phagocytose. Yes, that is possible, but they can't kill the organism. They can phagocytose but can't kill. But they can't kill the organism because the defective oxidative burst and respiratory burst. They cannot produce oxygen free radical, they cannot produce the hydrogen peroxide, and they can't produce the like hydroxyl halide free radicals as well. So they cannot kill the organism by oxygen dependent killing. And what infections? Obviously, this is going to result in recurrent infections. And what infections they are going to get? Typically, catalase positive organisms. Remember, the catalase positive organisms already they are trying to escape the oxygen dependent killing and respiratory burst by the neutrophil. But if there is no respiratory burst, these organisms are going to thrive, and the patient is going to get repeated infections and recurrent infections from catalase positive organisms. So which means they are going to get recurrent infections. That means they are going to get recurrent bacterial and fungal infections, especially from Candida. Bacterial and fungal infections. Recurrent bacterial and fungal infections they are going to get. So if they develop recurrent bacterial and fungal infections, but they can't kill the organisms, so the body will try to form a wall. So the infection will still be there. So for example, if you ask me, this is the infective focus. The body cannot kill the organism by respiratory burst, especially the catalase positive organisms. So they try to wall off the infection by forming granulomas. So that is why many of the areas you will see the granulomas in this patient. That is why this disease is also referred to as something called a chronic granulomatous disease. Very simple. So investigation wise, how will you diagnose this chronic granulomatous disease? If you ask me, this patient is going to have a normal neutrophil count, number one. So which means there is no neutropenia or neutrophilia, like we have discussed in leukocyte adhesion defect, isn't it? Leukocyte adhesion defect, you have neutrophilia, and lazy leukocyte syndrome, we saw neutropenia. But here there is no neutrophilia or neutropenia. The patient will have a normal neutrophil count. But where the patient will be having problem is the NBT test positive. The NBT test will be positive. That is called nitroblue tetrazolium chloride. Nitroblue tetrazolium chloride. So this test is going to be positive. So what do you mean by nitroblue tetrazolium NBT test? Here what is going to happen is you have a blood sample. And you are going to add this molecule. That is, this NBT molecule is going to be added. So NBT is going to be added. So if NADPH oxidase is intact, so suppose if this blood contains NADPH oxidase, they are going to generate O2 free radical, and this O2 free radical is going to change the color of this NBT to blue color. It's going to change the color of this NBT to blue color. So which means you will see a blue color if NADPH oxidase is present. If NADPH oxidase is not present, the blue color will not happen. That is indicating deficient production of oxygen free radical, which means it can be only due to NADPH oxidase deficiency, thus telling the patient is likely suffering from chronic granulomatous disease. So right now the NBT test is not that reliable, so we use another test called DHR123 test, that's called dihydrorhodamine test. So this is a very important test, and this is what is currently preferred test and is actually done by flow cytometric principles. So that is what we refer to as like dihydrorhodamine test, DHR test, or DHR123 or dihydrorhodamine 123 test. So what we are going to do is you are going to again take a blood sample and we add two compounds. One, we had this DHR substance that's called dihydrorhodamine, and we also going to add a stimulating substance called as PMA. We are going to add a stimulating substance called PMA, that's called Forbol myristate acetate. acetate. So what happens is when you add this, for example, the neutrophil within the blood will take up this DHR, and this uptake of DHR, dihydrorhodamine, will be stimulated by this. This uptake of DHR will be stimulated by this Farbol myristate acetate. So that's why we add this compound. So inside the neutrophil, for example, if you see, if you take once the DHR has been taken by the neutrophil, what happens is, if there is a generation of O2 free radical, this O2 free radical will convert this, because this O2 free radical can be only produced by NADPH oxidase mechanism. So what will happen is, this O2 free radical, once it's produced, they will produce a green fluorescence. They are going to produce a green fluorescence. This DHR will produce a green fluorescence. This green fluorescence can be detected by the flow cytometry. Remember, DHR can be taken up by the neutrophil only by stimulating with PMA. So add PMA and DHR together. DHR will be taken up by the neutrophil, and inside the neutrophil, if there is a O2 free radical, because if there is NADPH oxidase, you will produce O2 free radical. If it is there, the DHR, dihydrorhodamine, will turn into a will produce a green fluorescence by mingling with O2 free radical, and that can be detected by flow cytometry. And I'll show you the results of flow cytometry. The advantage of this test is it can detect even the carrier state as well. So that is why it's very, very important. So they can detect the carrier states also, which I'll show you in some time how to find out this DHR based assays. And treatment wise, if they ask you, only thing that you can use is interferon gamma. That's the only treatment, because interferon gamma can increase the oxygen free radical production by stimulating NADPH, or whatever NADPH oxidase is available, they stimulate and they can produce this excessive O2 free radicals. And probably, like finally again it comes that allogenic hematopoietic stem cell transplant, because you have to replace the neutrophils with the new neutrophil from a donor. So nothing else you can do about it. So this is a genetic defect. So this is the allogenic stem cell transplant. So these are the treatment for this chronic granulomatous diseases. And one more interesting syndrome is there, that is called McLeod syndrome. It's a very interesting syndrome. Why it is interesting? Because McLeod syndrome is due to deletion of KEL antigen, otherwise called as XK. That's called KEL gene, KEL antigen defect. So this actually is a blood group antigen. This XK is a blood group antigen, so which means it's a KEL gene defect. KEL gene is again present on the X chromosome. So, but in what way it is related to the neutrophils? Very simple. Remember, this KEL gene is in very close proximity to the CYBB gene. It's in very close proximity to this CYBB gene. So we know that CYBB gene is the one that is going to give rise to NADPH oxidase. And the KEL antigen, KEL gene is the one that is going to give rise to something called KEL antigen, that is XK antigen. So that's a KEL blood group gene. So in McLeod syndrome, there is deletion of KEL antigen or deletion of KEL gene. That's what you will result in McLeod syndrome. But sometimes, in certain cases, the deletions can be extending. So in certain, not all cases of McLeod syndrome, there can be deletions of both KEL as well as CYBB gene, which means patient will have CGD. In certain cases of McLeod syndrome, not all cases of, again remember, certain cases of McLeod syndrome, patients may have chronic granulomatous disease as well. So what will be the features in this scenario? Patient will have hemolytic anemia because of KEL gene deletion, and KEL antigen is not present. At the same time, this anemia will also contain numerous acanthocytes in the peripheral smear. Patients will have cardiac involvement in the form of cardiomyopathy. Patient will have CNS involvement in the form of seizures, dementia, choreoathetotic movements, and all these things. At the same time, patients may have peripheral neuropathy also. Peripheral nerve system may also be affected. At the same time, patients may have additional chronic granulomatous disease if CYBB is also deleted. If CYBB is also deleted, so I haven't write also here, if CYBB is also deleted, so which means KEL antigen deletion will result in all these problems, but additional CYBB deletions can also result in chronic granulomatous disease, which is a known association with McLeod syndrome. Not all the cases, few cases where additionally you will have both KEL as well as CYBB gene deletions. So if you want to know how this things are going to be seen in flow cytometry, you can see this picture where you can see this one is the normal thing. This is actually like dihydrorhodamine test. Stimulated means I am going to stimulate with, as I told you, I am going to stimulate with PMA, that is formol myristate acetate. So you can see unstimulated, they don't take up the DHR at all. Obviously you can see the reports are typically negative. You are not seeing DHR fluorescence at all. So remember, this is the increasing number of fluorescence, amount of DHR fluorescence that you see. Here you see very less amount of DHR fluorescence is seen. It's a single peak. So that is negative actually in unstimulated patients. The moment you stimulate with PMA, the neutrophils will take up the DHR, and since normally neutrophils contain NADPH oxidase, they are going to produce O2 free radicals, which are going to produce a high amount of green fluorescence. Simple, which can be detected by flow cytometry. And in a X-linked chronic granulomatous disease, what you can see, whether it is with unstimulated without PMA or if it is stimulated without PMA, you are going to see only low level of DHR fluorescence, which means after PMA uptake is there, but DHR fluorescence is not seen because you don't have NADPH oxidase in these patients. And next thing what you are going to see is carrier state. I told you one of the advantages of DHR, because this cannot be found out in NBD test. One of the advantages of this DHR fluorescence assay is you can detect the carrier states also. So how can you detect the carrier states? You can see here in unstimulated, obviously there will be no uptake. You don't see anything in unstimulated patients as expected because they have not taken up the DHR yet. But in stimulated things, you are seeing a little bit of DHR uptake and DHR fluorescence, but there are certain things which are still negative as well, which means there are two biphasic populations. There some neutrophils are having NADPH oxidase, which means those are producing the DHR fluorescence, and certain cells are not having NADPH oxidase that are producing no DHR fluorescence, which means a mixed population means it's a X-linked chronic granulomatous disease carrier state. That is the advantage of the DHR fluorescence, which can produce the carrier state also. So what are the other problems? Other problems you can talk about myeloperoxidase deficiency. Second one, apart from the chronic granulomatous disease, you can talk about the myeloperoxidase deficiency. Myeloperoxidase deficiency is the most common disorder of neutrophil function. Very important point. Most common disorder of neutrophil function, and is autosomal recessive in inheritance. If they ask you acquired forms, where will you see? Acquired forms can be seen in acute myeloid leukemia or acute myelogenous leukemia. You can see an acquired form of MPO deficiency. This is also old Ames question in 2015 they asked it. So this is what we called as acquired form of MPO deficiency, where you can see in AML, acute myelogenous leukemia. MPO deficiency means MPO, where it is important. I told you oxygen, to become oxygen free radical you need NADPH oxidase, and to become H2O2 you need superoxide dismutase, and to become hydrogen halide free radical you need hydrogen halide free radical, you need this myeloperoxidase, which means this is where the defect is, which means they cannot convert into this hydrogen halide free radical. So that is where the problem is. This production will be decreased, which means they will have the oxidative burst. Neutrophils will have normal oxidative burst, so which means they can produce the oxygen free radical, which means there will be a normal NBT test. Since they produced oxygen free radical normally, they will have a normal NBT test and they will have a normal DHR 1, 2, 3. That is dihydrorhodamine 1, 2, 3 test. Everything will be normal. There will be no problem in this because they have a normal free radical production. But what is the problem here? Actually, in MPO, the patient will be typically asymptomatic and they will have a normal neutrophil count, which means like chronic granulomatous disease, there won't be any neutrophilia or neutropenia at all, and the patient will be typically completely asymptomatic. The only thing they will be having is a delayed microbicidal action. Delayed microbicidal activity, but it's not absent. Whereas in chronic granulomatous disease, there is no oxidative burst and the microbicidal activity is lost in chronic granulomatous disease, but here it is only delayed, but it is not absent. Very important. The patient will have a normal NBT and normal DHR assay. There won't be any problem in that because they can produce the oxygen free radical, and the oxidative burst and respiratory burst is still intact in these patients, only delayed microbial activity, but it's not lost. And it's also one of the most common disorders of neutrophil function, and it's inherited as an autosomal recessive disorder. Acquired forms can be seen in AML. Very important. Again, myeloperoxidase deficiency. And the third one, you have something called Chediak-Higashi syndrome. That's called CHS. If you want to write, you can write Chediak-Higashi syndrome. So usually the problem in Chediak-Higashi syndrome is due to gene called List gene defect. So this is called lysosomal trafficking regulator. This list is also called as lysosomal trafficking regulator. That's what we call List. Or otherwise, this List gene is also interchangeably called in many textbooks as something called CHS1 gene. That's called Chediak-Higashi syndrome 1 gene. Both are the same only, and it is inherited as autosomal recessive inheritance. The problem is, I told you, in a neutrophil, you have formed a phagosome and you have a lot of lysosomes, and these lysosomes has to fuse with the phagosome. For example, if you ask me, this is the phagosome and this is the lysosome, means they have to fuse with them. And for fusion, you need this list. That's called lysosomal trafficking regulator. If list gene is defective, means your phagolysosome formation will be defective. The phagolysosome cannot be formed. So which means the lysosome cannot fuse with the phagosome where there is microbes. Microbes are present in the phagosome only. So that cannot be killed. That is, again, it's a killing defect only. So that is what we called as Chediak-Higashi. So usually it is going to come with a characteristic triad. That is called, first is albinism. And second one, the patients will have something called recurrent pyogenic infections. Recurrent pyogenic infection, that is due to defective mingling of the lysosome with the phagosome and poor phagolysosome formation. And third one, the patient will have something called peripheral neuropathy. Peripheral neuropathy. That is what also going to happen. So the main problem is, remember, this fusion is very important for the granular release also. This list is not only important for fusion of the phagosome with the lysosome, it is also very important for the release of the granular contents. You know, like the neutrophil granules, I didn't talk about that. The neutrophil granules are very important. The neutrophil granules are nothing but the modified lysosomes. Very important. The modified lysosomes is what we refer to as the neutrophil granules, and the neutrophil granules are typically defined into alpha granules, or otherwise called as azurophilic granules, or otherwise referred to as primary granules. And the second one, you have something called secondary granules, or otherwise also referred to as something called specific granules. And the third one we also called as tertiary granules. And these are the things that are important for very important process called oxygen independent killing. Because till this time we saw something called oxygen dependent killing, but I didn't tell you what you mean by oxygen independent killing. But this is very important process that is helpful in oxygen independent killing, the neutrophil granules, the lysosomes of the neutrophil. What are the contents of the primary azurophilic granules? Remember, this azurophilic or primary granules or non-specific granules or alpha granules contain compounds such as acid hydrolase. Then you have something called BPI, bacterial permeability increasing molecule, that's called BPI. Then you have cathepsin G. Then you can have defensins. Then you have elastases. Then you have MPO, myeloperoxidase. And then you have something called peroxidase. Remember, this peroxidase is the one that differentiates this azurophilic granules from other lysosomes, because other lysosomes usually does not contain this peroxidase. Only this azurophilic granules or azurophilic lysosomes will contain the peroxidase enzyme. So that is what is very important. And why it is called non-specific? Because it is not only seen in the neutrophils, it's also seen in the other granulocytes. It's also seen in other granulocytes, and it can also be seen in lymphocytes, and it can also be seen in monocytes, which means it's not specific. It's not only seen in neutrophils alone, but it's very important for neutrophils, but not only seen in neutrophils. That's what the idea is. At the same time, I told you before itself, azurophilic granules are the ones that form very early. That is in the promyelocyte stage itself. But that is the one important difference with the specific granules or secondary granules that form in the myelocyte. They are little bit smaller in nature, but they are very numerous. But these azurophilic granules are larger but less in number. But this specific granules are smaller, but they are numerous, many in number. At the same time, they develop a little bit later. As I mentioned in the beginning itself, in the neutrophil, in the WBC basics, they form in the myelocyte stage only. They don't form in the promyelocyte stage, they form in the myelocyte stage. And very importantly, they contain certain substances like collagenase, they contain certain substances like cathelicidin, they also contain NADPH oxidase, which is defective in your chronic granulomatous disease, and they also contain lactoferrin, and they can contain alkaline phosphatase. And remember, these granules do not stain with Romanowsky stain. Very important. Remember, only the azurophilic granules commonly stain with your Romanowsky stain, but these specific granules generally do not stain with Romanowsky stain. Very important. And again, they form a little bit late. And tertiary granules are completely different. They contain other cathepsins apart from cathepsin G, and they also contain gelatinases. These are things that are contained in tertiary granules. Very important thing. Remember, all these granular contents are very, very important for oxygen independent killing. Very important. These are not important for oxygen dependent killing. They are important for oxygen independent killing. So which means the problem with Chediak-Higashi syndrome is defective oxygen independent killing, which means they cannot pour the lysosomal content into the phagosome. That is where the problem is, which means myeloperoxidase deficiency, NADPH oxidase deficiency, and chronic granulomatous all are defective oxygen dependent killing. But whereas your Chediak-Higashi syndrome is defective oxygen independent killing. So that is what is very important. Defect in oxygen independent killing. So what are the other features? So I told you they result in classical triad of albinism. They can result in recurrent pyogenic infections, and they can result in peripheral neuropathy. This is a characteristic triad of Chediak-Higashi syndrome. Apart from that, these patients can have problems in defective platelet granular release also. So which means these patients can also present with bleeding diathesis. This patient can also have associated bleeding diathesis, because in platelet, for example, if you take a platelet, in the platelet you have granules within the platelet. So this granular content within the platelet also cannot be released, because platelet granular content release is very important for platelet adhesion and aggregation. And again, if this is not able to be released, then definitely you can't produce proper platelet adhesion and aggregation. So that is the reason this patient also present with bleeding diathesis. And for that also you need that list gene. Again, the platelet granules are also made of lysosomes only, from lysosomes only. So that's why this is very important. And patients, some few patients can enter something called accelerated phase. Accelerated phase, where they present with HLH-like picture, that is called hemophagocytic lymphocytic histiocytosis, which I'll discuss in some time. So in the histiocytic disorders, so they can also present with something called HLH-like picture. And patients may have associated neutropenia. Patients may have associated reduced chemotactic responses. The neutrophil chemotaxis may be reduced itself due to unknown reasons. And the patients may have reduced NK cell activity also. And again, for NK cell activity, the granular content release is very important. They release these granzymes, perforins, and that's how they kill the target cell, the natural killer cells. And again, for that you need this lysosomal granular contents to be released. And again, LIST gene is very, very important. That lysosomal trafficking regulator is again very important for release of the granular contents. Again, here it is defective, so NK cell activity also will be reduced. So 3 areas you are seeing defects. One is your neutrophil granular content release defects, and again second is platelet granular content release defects, and third thing NK cell granular content release defects. All these things depend on the granules and the release, and the granules are made of lysosomes. That is the reason why these are defective in these patients. So, but apart from that, in exam, always albinism, recurrent infections, peripheral neuropathy typically goes towards Chediak-Higashi syndrome. Very, very, very important. Only by genetic methods you can diagnose Chediak-Higashi syndrome. You cannot diagnose by your NBT test or anything else. Only your genetic testing can determine the problem. Treatment, only curative option is allogenic stem cell transplantation, and plus you have to give prophylactic antibiotics to these patients, because these patients are highly prone for infections. And diagnosis wise, you can do in the peripheral smear. In the peripheral smear, one important finding you will see, that is called giant azurophilic granules. You will not only see in the neutrophils this giant, because azurophilic granules, I told you can see in other granulocytes also. So it can be seen in your neutrophils, you can see in the eosinophils also, and you can probably see in the monocytes also. So there will be giant azurophilic granules typically seen in the neutrophils. So I didn't show you that, but you can see, if you see this kind of picture in the exam, this is typical of Chediak-Higashi syndrome, because they are showing the giant azurophilic granules you can see in the neutrophils and the eosinophils. These are nothing but the giant azurophilic granules. Why you see giant azurophilic granules? Because this content of the granules cannot be released into the phagosome, and they remain stored within the lysosomes, and they cannot empty them. That's why they become bigger and bigger in size, and that's why you get the giant azurophilic granules. And this kind of giant azurophilic granules can also be seen in the melanocytes. Melanocytes, typically when you take a biopsy near the hair or the nerve tissue, like when you near the hair or nerve tissue, when you take the biopsy from the skin and see the melanocytes, you can see this giant azurophilic granules, because melanocytes also release their contents to look black. The pigmentation is because of the release of the melanocyte granules, and that is also the reason why the melanocytes cannot release their granules, and that is the reason why these patients also suffer from albinism as well. So very simple. Peripheral smear showing giant azurophilic granules. So how will you diagnose Chediak-Higashi syndrome? Remember, Chediak-Higashi syndrome is problem due to defective killing by the neutrophil, especially the defect is in the oxygen independent pathway, where the lysosomes cannot mix with the phagosomes. Very important. So since the lysosomes cannot mix with the phagosomes, they cannot form a phagolysosome, and because of that, the granular content of the lysosome, that is especially azurophilic granules, cannot be released into the phagosome, so that the granules become bigger, and that's what is in the peripheral smear in the form of giant azurophilic granules. And typically in exam you will get that albinism, very, very important, and second thing you will get peripheral neuropathy, and third thing you will get recurrent pyogenic infections in the patient. And peripheral smear, I told you, giant azurophilic granules. Apart from that, you can see the same in the melanocytes also, in the form of giant granules in the melanocytes when you take biopsy in the skin near the hair or the nervous tissue. So this is what is going to happen. And the patients may have bleeding diathesis and reduced NK cell activity also because the same reason, because platelet granular contents and NK cell granular contents also cannot be released. And treatment is only allogenic stem cell transplantation. And next thing, there are two benign disorders of the neutrophils. After celiac, these are something disorders of neutrophils, and two benign disorders of neutrophil. One is the Pelger-Huet anomaly. That's called Pelger-Huet anomaly. This is one of the benign disorders of the neutrophil, where the neutrophil nucleus will be bilobed or reduced lobation or reduced lobes of the nucleus of the neutrophil. Reduced nuclear lobes. Here you can see bilobed nucleus in the neutrophil. So this is typical of a Pelger-Huet anomaly, where you have a reduced number of lobes. And if they ask you what is the reason for this Pelger-Huet anomaly, it is autosomal dominant due to defective laminin B receptor. This is due to laminin B receptor defects, and you will see and it's an autosomal dominant inheritance, and it's a very benign condition. There is no problem with this Pelger-Huet anomaly. But very importantly, in exam where they will ask you is acquired Pelger-Huet anomaly, where you will see classic example MDS, myelodysplastic syndrome. This is one thing, if you know, that is more than enough for exam, MDS. But apart from that, you can see in AML, you can see in CML, you can see in, this is CML, you can see in CML, you can see in myxedema, hypothyroidism, you can see in B12 and folate deficiency. But as far as I know, very important is MDS, that is due to ineffective erythropoiesis producing dysplastic amount of neutrophils in MDS. So very important. One of the important dysplastic neutrophil look that you get in the peripheral smear in MDS is Pelger-Huet anomaly. But anyway, so in MDS is the most important, where you see, where in acquired conditions they also refer to as something called acquired Pelger-Huet, or also called as pseudo Pelger-Huet. Pseudo Pelger-Huet anomaly or acquired Pelger-Huet anomaly. And next thing where you can see is something called a May-Heglin anomaly. May-Heglin anomaly. May-Heglin anomaly, what you can see here, if you zoom and show you, you can see this kind of basophilic inclusions. These are very large basophilic inclusions. These are cytoplasmic inclusions, isn't it? Large basophilic cytoplasmic inclusions in the neutrophils. They generally resemble Dole bodies. These are not Dole bodies, but you can see here also. These are large basophilic cytoplasmic inclusions within the neutrophils, which may resemble Dole bodies. This May-Heglin anomaly is also another benign disorder of the neutrophil. Again, it is due to autosomal dominant inheritance due to MYH9 mutations on chromosome number 12. It's due to MYH9. Laminin B receptor is Pelger-Huet, and May-Heglin is due to MYH9 autosomal dominant in inheritance. And these patients may also have associated giant platelets, and they may also have mild thrombocytopenia, which can result in mild bleeding and purpura, not severe anyway. They can result in mild thrombocytopenia and mild bleeding possible. So this is what we call May-Heglin anomaly. Again, another benign disorder of the neutrophil. Pelger-Huet anomaly is reduced number of lobes of the nucleus, typically a bilobed nucleus or dumbbell-shaped nucleus, is due to laminin B receptor mutation, autosomal dominant inheritance. Most important acquired cause, that is pseudo Pelger-Huet anomaly, you see in MDS, myelodysplastic syndrome. And May-Heglin anomaly is due to large cytoplasmic Dole-like inclusion bodies that you see in the neutrophils, typically due to MYH9 gene mutations. Again, it's autosomal dominant. Patient may have associated giant platelets and mild thrombocytopenia, which may result in mild bleeding or purpura. But these are the benign disorders of the neutrophil. But that comes to a conclusion. And finally, what are the things that we saw in the disorders of the neutrophil? Is two things. One is we have seen oxygen dependent killing defect. Oxygen dependent killing defect, we saw only one thing, that is chronic granulomatous disease. And oxygen independent killing, we saw a very important defect, that is something called Chediak-Higashi syndrome. And one thing that bridges between these two is the myeloperoxidase deficiency, which you can take it as problem of the oxygen dependent killing or problem of the oxygen independent killing, because myeloperoxidase is coming from lysosomal granules also, granule content of this thing also, and MPO is also important for the oxygen dependent killing process. So you can remember it's a bridge between these two. Most common neutrophil function defect is MPO deficiency, that is myeloperoxidase deficiency. Remember, patient will be asymptomatic in MPO deficiency. In all these defects of neutrophil function, patients will not have, especially in MPO and chronic granulomatous disease, patient will have normal neutrophil counts. Normal neutrophil counts, very important. In Chediak-Higashi syndrome, patient may have either a normal neutrophil count, or especially during accelerated phase, patient may have a neutropenia. But apart from that, typically this is what is going to happen. And here in CJD, the patient will have recurrent infections plus formation of granulomas and positive NBT test and positive DHR test, DHR assay, dihydrorhodamine 1,2,3 assay. So this is what is going to happen. Whereas in MPO, patient will be asymptomatic, I told you already, but in Chediak-Higashi syndrome, you will get the characteristic triad of albinism, peripheral neuropathy, and patient will have recurrent bacterial and fungal infections as well. And in peripheral smear, you will see giant azurophilic granules. In all these conditions, the basic treatment will be allogenic stem cell transplant. And interferon gamma you can use in chronic granulomatous disease as a treatment option, but you cannot use this in any other option. So these are some of the important MCQ points that you have to know for exam. And two benign disorders of neutrophils also I told you, that is May-Hegglin anomaly and Pelger-Hutt anomaly. I told you about the pseudo-Pelger-Hutt anomalies as well. Finally, where will you get this congenital neutropenias? Where will you get this congenital neutropenias? Congenital neutropenias can be classified into three things. One is you have something called Elaine defects, or this is something called ELA2 defects, are otherwise called as problems of the neutrophil elastase, and these disorders are generally autosomal dominant. Second one, you have something called WHIM syndrome, and third one, you have something called a Monomax syndrome. And third one, you have something called others, which we'll discuss. Already we have discussed this. These Elaine defects again are divided into two types. One is called severe congenital neutropenia. And second one, you have something called cyclical neutropenia. Depending on the severity of the neutrophil elastase gene, that's called Elaine defects. Cyclical neutropenia. In severe congenital neutropenia, this is otherwise referred to as Costman syndrome. This is otherwise called as KOSTMAN, Costman syndrome. And typically the neutropenia is persistent in this condition. Whereas in cyclical neutropenia, the neutropenia is cyclical, where typically it happens every 21 days and lasts for 3 to 5 days. 3 to 5 days of neutropenia will be there, and again it will recover, and after 21 days again you will get another attack of neutropenia lasting for 3 to 5 days. So this is what you get, a cyclical neutropenia. Both are due to Elaine defects only. This patient is at increased risk of AML and myelodysplastic syndrome. These patients are not. Definitely Costman syndrome patients are at very high risk of developing leukemias, AML and myelodysplastic syndrome, whereas cyclic neutropenia patients don't have high risk of MDS and AML. Similarly, in WHIM syndrome, it actually is an acronym that stands for something called WATS. Then you have hypogammaglobulinemia, then you have recurrent infections, and you have myelocathexis. What do you mean by myelocathexis? Myelocathexis means the neutrophil will be pooled in the bone marrow itself. Pooling of neutrophils in the bone marrow. They are not released into the circulation at all, which means the neutrophil production is normal, but they cannot come out. It is different from lazy leukocyte syndrome, where they are also pooling of the neutrophils in the bone marrow, but there the problem is the chemotaxis defect. Here there is no problem with the chemotaxis. Here the neutrophils rather, they get strongly bound to the bone marrow. Probably that is the reason why we think it probably might be due to CXCR4 gain of function mutation. CXCR4 gain of function mutation, and again it is an autosomal dominant. disorder. Probably a CXCR4 gain of function which holds this chemokine receptor holds the neutrophil within the bone marrow rather than releasing it out of the bone marrow. So they get pooled within the bone marrow and they don't get released into the peripheral circulation at all. So this is what we called WHIM syndrome, Warts hypogammaglobulinemia, infections and myelocathexis. And you have something called a Monomax syndrome. This is also referred to as something called familial MDS and AML, which is again autosomal dominant disorder, and again it is due to inactivating mutations of GATA2 transcription factor. Loss of function mutations of GATA2. GATA2 is a very important transcription factor which we discussed in basics of hematology itself. And again this is a GATA2 transcription factor mutations, autosomal dominant, otherwise referred to as familial MDS or AML syndrome. So where the patient will have monocytopenia, patient will have neutropenia as well, but no, monocytopenia is what is very important. At the same time, patients may have B and NK cell lymphopenias also. B and NK cell lymphopenias. Because of that, lot of cell lines are defective, so the patient is at extremely high risk of infections. But what is very, very important is that this Monomax syndrome is a very, very highly precancerous disease, which means they are at very high risk of AML and MDS. At the same time, they are at very high risk of vulvar cancer. They are at very high risk of metastatic melanoma. They are at very high risk of leiomyosarcoma. At the same time, they are at very high risk of cervical cancer also, cervix cancer also. So which means it's a highly, highly precancerous lesion. That is why this is also referred to as something called familial MDS and AML syndrome, otherwise referred as Monomax syndrome, where the patient will have monocytopenia and neutropenia. Along with it, they will have B and NK cell lymphopenia. All these cell lines will produce high risk of infections and a very, very highly precancerous disease, Monomax syndrome. Others we discussed already. One is the characteristic Shwachman-Diamond syndrome, which we already discussed in the bone marrow failure syndromes. And next thing, patients will have something called Chediak-Higashi syndrome, especially in the accelerated phase. I told you the patients will have neutropenia. Some time back only I told you that is called Chediak-Higashi syndrome. There is another disease called benign ethnic neutropenia, where typically seen in African population. Probably it is a protection against malaria because this is due to mutations of the DARK receptor. Remember, this DARK receptor is present in both neutrophils as well as the RBCs. This DARK receptor, the YVAX, for example, especially YVAX enters the RBC through the DARK receptor only, this DRC receptor. So DARK receptor mutations prevents the YVAX from entering the RBC. At the same time, this DARK receptor mutations affect the neutrophils also because it is present in the neutrophils as well. So which will reduce the neutrophil count by a little bit, by approximately 500 per microliter compared to the normal population. This is what we refer to as something called benign ethnic neutropenia, which is due to DARK receptor mutation, DRC receptor mutation. So these are some of the conditions that produce neutropenia as well. So these are the conditions that produce congenital neutropenia, where you have LN2 GFX, which is nothing but severe congenital neutropenia, otherwise called as Kossman syndrome, versus you have something called cyclical neutropenia. At the same time, you can have WHIM syndrome, you can have Monomax syndrome, and you can have other syndromes which I have discussed already, like Chediak-Higashi, Shwachman-Diamond syndrome, and you can also have something called benign ethnic neutropenia, which are due to DRC gene mutations. With this, we are going to complete the disorders of the neutrophils in detail. In the next section, we will be discussing on the histiocytic disorders.